So at the outset, this case looks like small pupil hard nucleus case, but as we inject the visco, we realize that with the two problems, there is third problem that nucleus is shaky. There is moderate to severe zonulopathy with phacodonesis. So I have decided to put iris retractors as iris retractors give a good peripheral view compared to other pupil dilatation devices. Before staining the anterior capsule, it's important to wash all the viscoelastics from the anterior chamber. While starting the capsulorhexis, we can see the nucleus is shaking. At this point, I shift from cystitome to capsulorhexis forceps as there's very less countertractions because of zonular weakness. And in this situation, the capsulorhexis forceps gives better control over the rhexis than the cystitome. After completing the adequate size capsulorhexis, I am doing viscodissection to create a plane just beneath the anterior capsule to insert this capsular tension ring. By doing the viscodissection, even the cortical cleanup becomes easier in the later stages of the surgery. I am giving support with the dialer from the other side and slowly threading the CTR in subcapsular plane. Now the bag looks pretty stable. It's important to completely break the corticocapsular adhesions because while rotating the nucleus, it causes unnecessary traction of the zonules if the corticocapsular adhesions are not properly broken. After making sure that nucleus is free from the capsule, I because the nucleus is hard, I've decided to do one deep trench and then do stop and chop. This is a rubbery hard cataract, and after the first crack, there's still the posterior plate is intact. So the sequential chopping helps in these cases to break the posterior plate. I've held the nucleus even deeper that helped me to crack the posterior plate. And after that, I'm chopping the one heminucleus into several pieces, repeating the same procedure for the other heminucleus. The pieces are slowly phacoemulsified. In this hard cataract, it's important to deliver the controlled phacoenergy to avoid the flying pieces in the anterior chamber. The anterior chamber is repeatedly filled with viscoelastics with the other hand to protect the endothelium from the excessive phacoenergy. As you can see, the irrigation and aspiration becomes very easier because of the viscodissection, and I did not have to try very hard on the cortical aspiration. Single piece hydrophobic IOL was injected in the bag, and the bag and the lens complex looks pretty stable. Now it's time to remove the iris retractors. Thorough visco wash is done from behind the IOL and from the anterior chamber. And that's it, the case is closed. On the first post-operative day, the patient was very happy with the unaided 6 by 9 vision, especially because his other eye was left was left aphakic somewhere else, mostly because of the same problem, small pupil, hard nucleus, and zonulopathy. And we posted his other eye for the scleral fixated IOL. Thanks for watching.